Thank you, Julia, and just congratulations. As a resident, she's pulled this program together from far away, and it's really good to see how she took time out of her training to go to the lab, and I'll show some of her data as part of her PhD. And to follow on from Greg, cancers are fruit salad, humans are fruit salad, and that complexity in how you respond to surgeries is another key driver that we need to understand better. So a broad overview again, with a little bit more focus on the TIVA volatile issue. No disclosures related to this topic. As you heard from Vijay, this is close to us. 1 in 3 of us will have a cancer diagnosis. If you count skin cancer, 1 in 2 of us will have a skin cancer diagnosis, and 1 in 4 of us are going to die from this disease. And so it's common, and it's increasing dramatically, and Vijay highlighted why. It's sociological factors, it's growth in the aging population, etc., our sedentary lifestyles, our diets, etc. And so with this increase, we're going to have to see a threefold increase in surgical capacity to meet the demands by 2030. Okay. All right. The global burden of disease, so all the diseases we know, a third are treated by surgery. When it comes to cancer and trauma, 2/3 need surgery, and that's important. And then for the challenge that the African country or the continent has, especially in the African continent, is that the inability to deliver primary surgery leads to 17% reduction in their GDP because they can't serve their population. And as a result, they can't provide surgery because they've lost the GDP. And that catch-22 situation is what, if you listen to Bruce Bickard recently and how he represented the state of surgery in Africa. Right. But more importantly, listening to Greg last night at sort of dinner, he said how Memorial Sloan Kettering are building more and more interventional labs, and where there's the interventionalists are needing anesthesia coverage as well. And so for diagnostic and interventional procedures, more than 80% of cancer patients now are exposed to anesthesia. So we better understand what our drugs are doing to these patients. And so while surgery is still the cornerstone of therapy, and we'll hopefully get most of our patients into remission, but we can see it's sandwiched in between immunotherapies and adjuvant therapies on both sides. So neoadjuvant therapy and adjuvant therapy after surgery, and the impact of those on our patients is important, and Vijay highlighted that to us. More importantly, surgery and anesthesia and the associated complications that go with surgery, these are noxious stimuli, and I'll try and show and highlight to you why. And Greg highlighted some of that as well. Non-cancer surgery, but I could have shown you a cancer procedure here, but this is non-cancer surgery. If this is the NISQIP database, 8-year follow-up. If you suffer a complication after surgery, your survival curve looks dramatically different, whether you're having cholecystectomy or AAA. And it'll be the same for mastectomy, and it'll be the same for colectomy. Importantly, you see that steep downslope there? That steep downslope there in mortality, that's patients who suffer complications. Those are the patients that aren't, well, if you suffer complications, you don't get to your adjuvant therapy. And that was highlighted as well. So we have an important role in making sure we can deliver. Why are those curves diverging? Well, here's the hypothesis, and I put it down in red, hypothesis, but this is interesting hypothesis-generating data. It's a retrospective cohort of patients having hip surgery, metal-on-metal resurfacing, let's call that minor surgery, and hip replacement, where the surgeon is reaming and hammering and causing this big surgical stress response. Look at the survival difference 10 years later. Now, you may say there were different age groups of patients, different indications. This was propensity score matched. There's something about the perioperative stress response that drives. And what were they? What was the drivers of the survival curve difference? Inflammatory diseases, cancer and heart disease. The patients were dying from cancer and heart disease 10 years later. Hypothesis generating. Cancer patients, a breast database in Italy. And what we can see here, there's a time related to the time of surgery in terms of recurrence. You can see there's a first peak in this Bi-Modal curve around about 16 months after surgery. And the second peak is about 3 to 4 years after surgery. What's driving this? Well, it may be that you've got dormant micrometastatic disease Now you have immune instability, and these microstatic diseases now escape, and they grow into cancers. It could be those circulating tumor cells that Greg highlighted there that are released during the time of surgery. You have an immune suppression around the time of surgery for about 7 days, and they have the time to have a foothold and grow into metastatic disease, and they may take a little bit longer to grow. And so we have this Bi-Modal curve, and the more aggressive the surgery, the more invasive, mastectomies, etc., this peak is going to be higher. And our fellow oncologists are saying the same thing. Radiation oncologists are saying there's something about our therapy that may be triggering recurrence. So we're not alone. We're not the only crazy ones out there. And so let's look at cancer. Cancer is really an inflammatory disease, and it's the stress pathways, it's the inflammatory pathways that converge, and they result in this proliferative state. Add the surgeon to that, and we have stress, and we have inflammation. And so that's why we have an important role of trying to dampen the adrenergic inflammatory response. Now, as Greg said, it's a fruit salad out there. It depends on your cancer type. Here we have cancers, that's murine cancers, those are human cancers. But what you can see is these express VEGF A and B, these express VEGF C and D. But look at the difference in the lymphatic dilation. And so what VEGF C and D do is they activate the COX pathway. And so VEGF C is a COX pathway activator, VEGF D is a prostaglandin dehydrogenase inhibitor. The net effect is increased prostaglandins, and what prostaglandins do, is shown by some of our researchers at Peter Mac, is they potent endothelial vasodilators of the lymphatic, or endothelial dilators, not vasodilators, endothelial dilators. And you can see here how the lymphatics are very vasodilated in these certain cancer types. And as a consequence, you have higher lymphatic nodes, and non-steroidals can suppress and or lymphoconstrict those diseases. So we were designed to survive this, okay, the woolly mammoth. And our teleological origins are one of mounting adrenergic response, running away from this woolly mammoth, and then mounting an inflammatory response if we get hit by the tusk of the animal. We've replaced that animal with a modern-day surgeon, okay? And essentially what you can see is activating of the stress inflammatory responses. You get cleavage of the microcirculation. That's where the circulating tumors get trapped. That's where they can embed and create new micrometastatic disease. The macrophages and the change of the immune system are intended to mop up bacteria, but they then mop up residual tumor disease and carry them back as lymphatic spread. So we've got this dichotomy of trying to protect, we need wound healing, but cancer growth works, you see the overlap in all these factors. Part of wound healing is pro-angiogenesis, part of cancer growth is pro-angiogenesis. And then on top of that, we add anesthetic technique, which I think just flames the fire. And that's the way I see that. Okay. And so what we're seeing here is this period of a cancer journey with this exaggerated biological perturbation and immune suppression, and this lasts for up to 7 days. And it's in that period that all of these factors that Greg highlighted may influence your survival. And it's how you respond as a patient, as a host. Some of us mount a hyperinflammatory response, others activate our innate pathways, and others of us activate our complement pathways. And so it depends on how we as patients are going to respond to the surgical stress response. And it depends on our tumors and what they express. But we have the opportunity to potentially modulate this response with the way we care for the anesthetic. And so this is a Nature Reviews Oncology. One of our PhD students, Jonathan Hiller, highlighted or did well, and I'd recommend you read it. It really is a good overview of the topic. Now let's add injury or insult to the injury. And as Vijay mentioned before, you have surgical wound complications. So you forget to give the second dose of antibiotics. You have poor fluid management, etc. And you now have wound complications. This is lung cancer. And if you suffer a respiratory complication after lung cancer, that's what your survival curve looks like. If you have a wound complication after breast cancer surgery resection, that's what your survival curve looks like. And what it is these are conditions that exaggerate the inflammatory response. That's my hypothesis, and I think that's how it's being driven. And now let's add fuel to this fire. Let's give them volatiles as opposed to TIVA. Now there's equipoise in the literature. But essentially, let's just start with an animal model. As you magnify, there's control, there's a bit of anesthesia exposure. Now we do a laparotomy. Here we start adding appendectomy. There we do a hepatectomy. And so magnitude of surgery increases, the inflammation increases, inject some tumor cells into the tail vein, and let's have a look at lung metastases 2 weeks later. And you can see how there's a dramatic increase in lung metastases. Let's do the same in a rat model. Let's inject exposure to anesthesia and control, nothing happens. But once you add surgery and you inject tumor cells, and now you do a laparotomy, you can see how there's a 17-fold increase in lung metastatic disease. And then once we start adding morphine and a spinal anesthetic and reducing that surgical stress response, we can see the beneficial effect. So important, while opiates may be harmful, don't avoid opiates at the risk of a surgical stress response. So the volatiles and the TIVA. So Greg showed this, Tim Wigmore, retrospective study, database analysis, propensity scored match. There's about a 10% absolute survival difference if you have TIVA versus volatile, predominantly driven in the GI cohort. It wasn't across all the cancers. But there's biological plausibility. Volatiles activate a lot of signaling pathways in the cancer pathways. For example, predominantly activate the HIF pathway, hypoxia-inducible factor, activate the MMP, so I can never say this word, MMP, myeloperoxide, help me out. Matrix metalloprotease, there we are. It helps break down barriers for tumors to invade and become metastatic, as well as inhibition of apoptosis. So these are all biological plausible aspects whereby volatiles can work. And therefore, when you look in Petri dishes and cell cultures, you can see this differential effect between propofol and volatiles in terms of all these different cell cultures, where the properties of the cells, and Juan's going to talk about local anesthetics. But what you can see is this opposing effect of volatile versus propofol in terms of cancer pathways. Volatiles decrease apoptosis, they increase proliferation, they increase migration and infiltration. And in the cell cultures, propofol has the opposite effect. They're also immune suppressant. So this is a nice review by Stallings in anesthesiology about how immune suppressant the volatiles are. Julia's animal model, so it's a xenograft with human breast cancer. And when these animals had mastectomy to take away the breast cancer, as well as laparotomy to increase the inflammatory response to surgery, we can see when the resection is done under volatile or under TIVA, there's a differential. And so this is bioluminescence, monitoring metastatic disease. We can see there's a rapid recurrence. But we haven't published this yet, because when Julia went back to clinical training, we got another technician into the lab, and we're seeing the opposite effect. And so suddenly the surgery was performed on larger tumors, and I think the quality of anesthesia wasn't quite as good. And so we're seeing volatiles probably had a better anesthetic technique than the TIVA group. And so we've got this conflicting data, so we've got to be careful with how we interpret this. Okay, but I think quality of anesthesia, quality of stress response reduction is important. Greg highlighted this. I think it's a good signal in the literature. Mats Enlund published this prior to Tim Wigmore, same signal, colorectal and breast cancer, difference in survival curve, retrospective data again. Gastric cancer, retrospective data again, survival difference if you have volatile versus TIVA. This is the U study, which Greg highlighted there, all comers for breast cancer surgery. And so there was a negative study, about 5,000 patients that were retrospective, but propensity matched. No survival difference in terms of disease-free survival or overall survival. Why? Well, if you look at this cohort, mastectomies only. This is another cohort where they looked at mastectomies. Now, there is a survival difference. So that heterogeneity of let's take all the wide local excisions and the mastectomies and combine them together is probably not the right approach. And so here's a slight differential signal between desflurane and sevoflurane, which is interesting. And so this is an infographic published after the U study in the January edition of Anesthesiology, where we can see this conflicting of, you can find studies on both sides of the argument. And so we were asked to write an editorial to accompany that, so Dan Cesar and myself wrote this, and it was a podcast in January. But essentially what we tried to highlight there was, I think it's the magnitude of surgery underlying all of this. We can't group them all together. These are different types of diseases, different types of surgical magnitude. So one of our junior faculty got them to do a meta-analysis of all these retrospective studies. And so there are about 8 retrospective studies out in the literature published recently in the Canadian Journal of Anaesthesia. Now, this is overall survival, and you can see on the left-hand side favors propofol. On the right-hand side favors volatile. And there's clearly a statistically significant favor in terms of TIVA anesthesia for overall survival. And it's largely driven by the larger surgeries, the esophagectomies, the gastrectomies, etc. This is the disease-free survival. Now, if you read the first edition of that publication, we made an error. So it suggested that there was statistically significant reduction in disease-free survival. But we switched by accident one of our data points. And so as a consequence, we've had published an erratum, and we've lost our statistical significance for disease-free survival. But when you do a sensitivity analysis and you remove the studies that contribute to the heterogeneity of the meta-analysis, we then once again have statistical significance for disease-free survival. So read it carefully and read the erratum as well. So has the data changed practice? This is all retrospective data. We as anesthesiologists are quite skeptic. Okay? And so this is a survey we sent out to Australasian anaesthetists, so Australia and New Zealand, and we asked them, do you use volatile? 18% of them say we use TIVA routinely. 82% prefer volatile. It's easy to titrate, it's easy to emerge, it's what we've been ingrained to use. And then when we asked them, do you think this literature is plausible? 40% said, yeah, there's something in it. 40% said, nah, this is all hogwash. And 10% couldn't make up their mind. But they're not changing practice. They're still using volatiles predominantly. And so 29% say if I do a cancer anesthesia, I probably will use a TIVA. So slightly up from the 18% to 29% if it's a cancer patient. But the majority of practice in the Australasian region is still volatile-based anesthesia. And so this is a survey by Boney et al. Where they've surveyed the UK public and said, what are the priorities for research and the anaesthetists? So more than 2,000 people participated in the survey. And we can see that they're saying, what is the long-term outcome of anesthesia technique is an important research question. And this is the equipoise in the literature I'm highlighting has led us to design a study called VAPOR-C. And VAPOR-C stands for Volatile Anesthesia and Perioperative Outcomes Related to Cancer. And so funded by our equivalent of NIH is the NHMRC in Australia, and we've received about 4.8 million plus another 1.2 from the Comprehensive Cancer Centre. So hopefully we can lead a multi-centre study, international, that can contribute to this. We did a feasibility study. 75% of patients are willing to be recruited. 98% of anesthesia assigned technique can be executed. We had 1 or 2 pump failures that we had to switch the anesthetic technique. But this is the study. It's going to be a 2-by-2 factorial design. It's going to be a pragmatic, international, single-blind because of the volatile TIVA, and it's going to be an event-driven study. We need 957 recurrences or death. And we're going to follow these. We estimate we need 5,800 or 5,700 patients. We're going to focus on 2 cancer types, and we're going to stratify by stage as well, and by center. And secondary endpoints will be morbidity and the impact of riot, the impact of long-term outcomes. But underneath this, the 2-by-2, we're adding lidocaine, and Juan will highlight why. And here's some data, Donald Buggy in an animal model. Basically, if they added lidocaine to sevoflurane, there was a reduction in metastatic disease in the animal model. And so there's some interesting aspects. And so these are the components of the, or centers. We're in the expression of interest phase, and so hopefully we'll have a multi-center international contribution to the study to execute it. The cancer field is advancing rapidly. We need to recruit into this as a combined specialty to execute this. So in summary, I think the most important aspect that determines your outcome is the cancer. It's the biology of the cancer. If you've got an aggressive GBM, it doesn't matter whether you have volatile or TIVA, it's not going to make a difference. But importantly, the periodic perturbation, whether you have complications, etc., is an important component, and we have control of that. And in the anesthetic technique, we can modulate it. And so here's your diagnosis. You undergo a cancer journey, you have neoadjuvant therapy, you have surgery. You need to get back onto your adjuvant therapy, your post-operative, for cancer survival. We as anesthesiologists have the ability to optimize our patients properly. We spend 4 to 6 weeks prehabilitating a lot of our patients, and we see them before neoadjuvant therapy and keep them functionally fit and optimize their hemoglobins, their functional state, etc. Reduce our complications through quality improvement programs. Vapor C's the volatile TIVA protocol we're proposing, but beta blockers and non-steroidals seem to have an important effect, neuraxial technique as well, and then post-operatively making sure that their patients recover well. And so the ERAS for the cancer patient, what you'll see through there is stress response reduction, it's anti-inflammatory technique, it's optimization, and in there, humidification of the peritoneal space. Cold CO2 is not good for the peritoneum. It desiccates it, it opens up the mesothelial junctions. So I thank you for your time.